Hi, I'm Stephanie Wells from iHeartRadio, and May is Stroke Awareness Month. And tonight, we're going to be talking about all things stroke, be it the signs of a stroke, also prevention, and LVHN being nationally recognized care, including rehabilitation and beyond. And joining me tonight is Dr. Isayev, who is Medical Director of Stroke Centers at LVH Cedar Crest and also LVH Muhlenberg. Thank you so much for joining us this evening.
Thank you for having me.
My pleasure. So first, let's start with the very basic. What is a stroke and what causes a stroke?
So there is a few different types of strokes, and I'll try to describe what we're looking for in those conditions. So the stroke is an interruption of the blood flow to the brain. And again, as I mentioned, there is two types of strokes. 80% of the strokes are ischemic stroke, which means there is not enough blood flow to the brain. It means that it's a large or small blood vessel get blocked, and the brain does not get enough blood, does not get enough oxygen. About 15–20% of the strokes are hemorrhagic stroke or bleeding strokes, or we call it intracranial hemorrhages. And with blood vessel rupture, and patient may bleed in the brain. Both conditions are critical conditions, and both conditions require immediate attention. And both conditions require immediate trip to the hospital.
So how is it determined which type of stroke has occurred?
Interesting that in the past, many years ago, we didn't know how to determine that except asking patients the question, ask the family the question, and do the exam. But thanks God, we have the new technology available to us, and this is the most important one, CAT scan. The CT scan or CAT scan is a technology that allows us to see some details in the brain, and first and foremost, help us to determine whether the patient has a bleeding type of the stroke, which a CAT scan will see immediately, 99.9% of the time, or it's an ischemic type of the stroke, which there is no blood. And then we move forward with other testing if needed to.
So based on that diagnosis after the CAT scan, does that change the treatment plan that is administered? And how does it change?
It does. It does quite a bit. So let's start with bleeding type stroke. Again, if you can imagine, if somebody bleeds in the brain, you have to make sure the patient is not taking any blood thinner medication. And if the patient is on blood thinner medication, then we have to reverse them. And we have a special compounds, special medication to help us to do that. The second very important thing is to make sure that we control the blood pressure, because every bleeding type stroke in the brain associated with the rise of the blood pressure. Is it either causing the rupture of the blood vessel and bleeding in the brain, or it's a result of the bleeding in the brain? And that very high blood pressure is a critical component of the patient that can make patient much worse. So if we do not control the blood pressure immediately, the patient may get much sicker. So that's a very important thing to do. And thirdly, very important thing to do is just put patient in the right place. In the right place mean patient has to be in the high volume stroke center where the professionals know how to treat this condition. And the high profile, high volume stroke center who have intensive care unit where those patients can be and will be treated.
Is it safe to assume that someone comes in as a stroke patient that they're all like high profile, the verbiage that you used, high intensity?
So the stroke is a critical medical condition, critical neurological condition. What is the bleeding one or ischemic one? Is the bleeding one with a rupture blood vessel and blood in the brain, or it's an interruption of the blood flow? So those are critical conditions, and that's why when stroke happens or you suspect the stroke happens, you have to be we have to rush to the emergency room. You have to rush to the emergency room, to the close primary or comprehensive stroke center, and where the ER personnel, our emergency department doctors, nurses know what to do, and whether the high profile, high level of neurological care is available to us. So I mentioned the bleeding stroke type of the stroke. Now, ischemic type of the stroke. Ischemic type of the stroke is the 2/3, 3/4 mostly of all strokes. It's when the blood vessel closed up and there's not enough blood flow to the brain. And if you show up in a hospital within 3 hours, preferably, sometimes 4.5 hours, or maybe 6 hours, but 3 hours is the best timing. You have a chance to get this blood vessel open, either with medication or with intervention. And it's a fairly new treatment and fairly unique treatment for the high-profile comprehensive stroke centers, which Lehigh Valley, Cedar Crest is one of them. Indeed. Is one of the first one, as a matter of fact, in the country.
And we enjoy you watching along, but if you have any questions, feel free to let us know in the chat room. I know we have some questions already standing by. As we mentioned, May is Stroke Awareness Month. 2 questions for you. Why is it so important to raise awareness about stroke? And I understand that Be Fast, which is what we're going to discuss now, used to only be FAST, and what led to the B and the E also being added in.
So when to be able to go to the hospital quickly, first and foremost, you have to recognize signs and symptoms of strokes. And FAST in the past, and now Be Fast now, as the little mnemonics that really help people to recognize the signs of strokes. And we recognize them, again, the most important things is not to take a nap. The nap will not cure your signs or symptoms of strokes, and when you wake up, you're probably going to be as sick as you were when you went to take a nap, or maybe even sicker. Mm-hmm. So FAST stands for the facial weakness or droopiness. The A stands for arm weakness, which arm weakness or leg weakness or both. S stands for the speech problem, and T stands for time. Time is important, and that's what I say, do not take that nap. Go right to the hospital. But we recognize that FAST mnemonics does not cover all types of strokes. And we recognize the same types of strokes will be missed if we only pay attention to this FAST. Right. And we then recognize and introduce B and E. And it fast become Be Fast. Mm-hmm. And the B stands acute balance dysfunction. So it's not a little dizziness here and there. It's suddenly that you cannot get up and walk straight line. It's suddenly that when you walk straight line, you really stumble and cannot walk. And you have severe, profound vertigo and dizziness with nausea and not feeling well. That's what the balance and B stands for. And E stands for the eye abnormality. So if you have acute loss of vision, one eye, or you have any eye movement abnormality, double vision or blurry vision, that can be the signs of a stroke. And that's what the E stands for. It's Be Fast. So balance problem, eye abnormality problem, loss of vision or blurry vision or double vision, F for the face droopiness, A for the arm or leg weakness, S for the speech disturbance, and T for the time. Again.
You repeated it without even me asking. Thank you. But I do have a question as it relates to.
We'll do it again.
Okay, good.
We'll do it again.
As it relates to the symptoms, is it typical for them to show up in rapid succession, or could it you just experiencing like one or two that then makes you want to go seek help?
That's an excellent question. Indeed, they not take place in any succession. They can be in random combination. It could be balance and eye movement abnormality together. It could be face droopiness and arm weakness and speech problem. And it usually happens like that within a minute. That's what the strokes is. It's when there is interruption of the blood flow or bleeding in the brain. It happens very quickly. So you have to react to that fast and rush to the hospital.
Very good. And I understand we have a question from our chat room. Lindsay, what are they saying?
Yes, I think it's perfect timing to talk about this. We have a question that's asking, are the stroke symptoms different from women to men? They can be different, it might not be all the Be Fast, but do certain ones present differently in men than women?
So again, that's a great question, because we know that, for example, heart attacks present very differently in men and women. And for decades, we were missing a lot of women with heart attacks because they present differently in women. When it comes to the stroke, there is a little less disparity. It's very similar. But again, because of a lot of women caretakers in the family and very often neglect their own health, we know and it's a fact, show up in the emergency room later than men. But overall signs and symptoms of stroke are very similar, because even though men and women may be wired somewhat differently, but major portion of the brain control the same function in men and women, and they present with the same symptoms. But most important thing, do not neglect that. Do not take a nap. Do not make a lunch for somebody else. Just go to emergency room.
Both men and women, but especially women. Yes, Lindsay.
We've got one more follow. I think it's maybe, I don't know if it's the right place to talk about it, but we'll talk about it. Someone's asking, is your life completely different after a stroke? I'm sure there are variances.
This is very important question, and I would like to maybe have a separate segment for that. Because it probably will take quite a bit of time and conversation, because it's a very important conversation, because your life may be different. And so let's talk about that and hide that and kind of tie that together to rehabilitation.
For sure, absolutely.
But definitely, please come back to that question, because I think it's a paramount question.
If I don't do it, Lindsay, you got to remind me, okay? Okay, I think you might have an opinion on this question. Does it matter where you go for care?
Well, yes, it certainly does matter when you go for care. So about, I would say, 15 years ago, medical neurological community, stroke care, treating community recognized that not every stroke center built the same.
Right.
And we realized that some stroke centers have completely different level of expertise and have a completely different levels of availability of high level of specialists. And at that time, we recognized that we introduced the first primary stroke centers who would treat a patient with the clotbuster medications. And then we have when the treatment advanced, we have a high profile center that can offer patients endovascular treatment. And we also offer patients the intensive care unit around the clot care. And at that time, few institutions stepped forward to put on the line their recognition and evaluation as a primary stroke centers, and then even further, comprehensive stroke center. And we were one of the first who in the primary stroke centers, and we were first in Pennsylvania, and second in the country as a comprehensive stroke center. Yeah, it's incredible. It's incredible.
And I understand that Lehigh Valley Hospital, Hecktown Oaks, has achieved that primary stroke center status. So tell us again what that means exactly.
So again, everything started with the primary stroke centers, was Lehigh Valley, Cedar Crest, and Muhlenberg, and then Lehigh Valley, Cedar Crest moved forward with the comprehensive stroke certification. Again, we were first in Pennsylvania, first in Northeast, and I believe the second in the country. And at that time, and that was great for our citizens here, for our patients. They don't need to travel anywhere to have the highest level of stroke care in the community. But we recognize that we cover the large areas, and not everyone can get in the hospital on time. So then we put a lot of effort to build the same expertise in the smaller community hospitals. And we introduced primary stroke care and primary stroke certification in Pocono and Schuylkill and Hazleton. So there was 4 primary stroke centers. And last week, our Hecktown Oaks got certified and become one more primary stroke center. It means that people who live in the Hecktown area, the eastern area, that actually can go to the primary stroke center and get incredible care so quick, right there at doorstep where they live. And I think it's incredible achievement of that hospital that just fairly young.
Yeah. Are strokes preventable?
Yes. So we strongly believe that with the proper medical care, a lot of strokes are preventable. So when we look at the hemorrhagic stroke, the bleeding strokes, and ischemic strokes, one of the biggest and most important things that we can do to prevent the strokes is to control the blood pressure. And the blood pressure is a silent killer. So if diabetes, at least you know that you're not feeling well when your sugar is very high, very low. Vast majority of the patients would not know that her blood pressure is very high. They just wouldn't know until somebody will check it for them, or they go to their doctor to be checked ever so often. And to control your blood pressure, you will save immense amount of strokes. And it's different in whites, in African American population, and Hispanic, because we know that actually blood pressure in African American population go unrecognized and are treated longer, and that causing a lot of strokes in African American population. The strokes in African American population in this country twice as often is actually in whites. And the same thing in the Hispanic population, it's almost twice as often as in whites. And I think it's because of the disparity of care, and because of the blood pressure particularly is not caught up early enough. But it's also very important to make sure that you don't smoke, Make sure that your diabetes is under control. Make sure that your cholesterol is checked and also under control. So this is the most important parameters that you need to watch to prevent the stroke. But again, blood pressure exceed significantly many other risk factors. There are other very important risk factors is your heart rate. There is a condition called atrial fibrillation. It's a irregular heartbeat that actually can cause quite significant strokes. The so-called embolic stroke, it's some little debris form in the heart when it's not pumping right, which have irregular heartbeat. It's about 25% of all ischemic stroke, maybe 30. But it actually counts up to the half of the very severe strokes, because we know that the stroke that caused by atrial fibrillation is more severe than other ones. And if you catch it and you check it before and you know what it is, that you have it, you can go on a blood thinner medication only and prevent that. It's a powerful, powerful treatment that's available today to prevent strokes from that irregular heartbeat.
Now, I hadn't heard about AFib being one in which you're more likely to,
Yes.
but my grandfather unfortunately had uncontrolled diabetes and as a result ended up having a stroke. So
we learned a lot about the diabetes, not only as a part of the that can cause a stroke as a preventative measures, but we know that when patients come to us with diabetes and very high glucose, the outcome is worse. So it's not only important to control the diabetes to prevent the stroke, but when patients come to us with very high uncontrolled blood sugars, we know that their prognosis is worse. So that's very important to control that.
And I saw a statistic somewhere that nearly 800,000 people have a stroke every year, but of that population, 80% of the strokes that occur could actually be preventable, and prevented, I should say, and based on what you just described.
Exactly. So we definitely believe it's 800,000. It's almost 1 million people will having a stroke every year, and and 2/3 of them can be prevented by controlling the blood pressure, checking your cholesterol, controlling your diabetes, make sure that you don't smoke, and you know your heart rate.
A question from our audience.
This is actually a question from me. I'm wondering if there are any genetic or environmental risk factors when it comes to stroke. And when I say environmental, I'm thinking, chemicals we're exposed to, air we breathe, stress we're under, very similar to how that can contribute to cancer. Is there any correlation between your environment, genetics, and that?
We know about some environmental factors. Again, the exposure to the drugs, for example, we know that fact, right? Cocaine, amphetamine, now cannabis is prevalent and ubiquitous, and some preparation, and we know in the community it is raising the question about how safe it is and unsafe it is, and because it's affect younger people. The exposure to pollutant clearly may play the role in that. We're not sure about it. We didn't really figure out exactly which one is worse, but we know some of them worse than others. Talking about genetic factors, there is clearly some genetic conditions associated with the stroke. There is some patients who may have the clotting conditions that can increase the risk of clotting in the blood. There is some genetic condition to increase fragility of the blood vessels. We know that a large amount of African American population have a sickle cell disease, so a sickle cell trait that increase your risk of strokes and bleeding, particularly in a young age if it's uncontrolled. So there is plenty of genetic information that we're gathering now and we actually available to us. And when we have the younger patient with the strokes who come to us, which we don't have any other common explanation like high blood pressure, like diabetes, cholesterol, and smoking, then we always check those unusual conditions, genetic condition that predispose people for increased clotting or expose them to some environmental things. We're also checking some unusual congenital disorders of the heart, like patent foraminopathy and etc., because it's also may play a role in the stroke risks.
Considering
I hope that answers your question.
Considering that there is genetic testing that determines or helps to figure out how susceptible you are to a cancer diagnosis, is there actually a genetic test that people could take or have done now that would see whether they're more likely to? I don't know if you already answered that question or not, but I'm just curious if there is a panel.
Yes, so that's an excellent question, because the answer is that no, we don't have that particular gene that tells me that if we have to check all of us here, and if it's high, then like in the breast cancer, for example, then if you're exposed to that, or maybe like in some other genetic condition that we need to check. But we know that in some patients who have young patient who's healthy, we go long distance to find those genetic abnormality. So we're not quite there yet, for good or bad, because we know when we start doing those genetic testing, a lot of time, insurance company may get a handle of that, and your insurance may go up with that, we don't know. But, so we don't do that in the general population yet. But any one of us sitting here, younger people who have a stroke, believe me, we're gonna do very extensive work of looking for genetic makeup to find if any genetic markers for condition that we know about. But research is going on, and we'll in the future we'll know more. But for now, we know some condition definitely associated with that. Brittle blood vessels that rupture, we know that there is there's a name for those different syndromes. We know that there is a genetic condition associated with the increased migraines and strokes in patients of European descent. We know that there is clotting conditions that associated with strokes, and it's particularly important, for example, for women who very often on birth control pills that may increase the risk of stroke forming, or because of the childbearing age. Again, when you have a baby, your blood getting thicker to prevent the bleeding, and it also may lead to strokes. But some patients may have this genetic condition that have even higher rate of clotting.
I don't know if this is a fair question, but we talk about the possibility of 800,000 people a year, having a stroke. Is there a certain age range of patients that you see, or what is the youngest, or is that, like I said, it might not be a fair question to ask in terms of the age?
The stroke generally viewed as a disease of older population. There is no question about it. And again, we believe in our area is the population-wise a little older than maybe some other areas, and that's why the risk of strokes goes up. So that's clearly as a risk factor. Again, when I say the race is the risk as a risk factor for the strokes, and also exposure to smoking, how prevalent the smoking is in some area of the United States or somewhere in Europe, for example. We know there is this condition, there's a geographical relation to the stroke called stroke belt that's include mostly southern states, that because of the smoking, because of the high percentage of African American population, and the food, which is a lot of fried food, which has a lot of unsaturated fats, right? So it does increase the risk of strokes. So, but it's a disease of older population. Young people also have strokes. And then again, then we go on a very long distance to find out why is that? Why the younger person who had no diabetes, hypertension, smoking, why the person had a stroke? Is it any genetic composition, any heart abnormality? Is it drugs involved, et cetera? So we can do maximum to prevent the second one.
Got you. I know we had another question.
One more question just popped up, and this might be age dependent, and I don't know, are there any preventatives one can take? Is it a vitamin? Is it eating organic food? Are those any kind of things that you can do?
Yeah, so prevention. So we talk about recognition of a stroke, right? We talk about that it's what to do when the stroke happens. We talked about two different types of strokes. We didn't talk what happened when you come to the hospital with stroke, but we should talk about that too. But let's do the prevention. So avoid going to the hospital with a stroke. Again, there is a primary prevention and secondary prevention. Primary prevention, the stroke hasn't happened. And that's probably what the question is all about. So that's really pertinent to almost all the cerebrovascular diseases. So what are that? That's obviously avoid being overweight. Don't smoke. Make sure that you check your doctors with your blood pressure. Make sure that, again, if you have a diabetes, you control your sugars. Make sure that you don't smoke. Then you make sure that your diet is healthy diet. So you your diet should not consist of the French fries and burgers every day. There is nothing wrong. Everybody enjoy the good fries and a burger from time to time, but it should not be the staples of your diet, right? So it have to make sure that it's include vegetables, it's include fish and fruits and so on and so forth. And being physically active, make sure that you try to get out. The weather finally allow us to be on the outside and spend some time outside. So, walking, exercising. Again, if you cannot walk, maybe you can, maybe swim or do something like that of some kind of physical activity. Those are primary preventative measures. And the secondary prevention, when a stroke happens, we may talk about that a little later, but that's the primary preventative strategies to avoid the stroke to happen in the first place.
I know that there was a question that we were going to get back to as its own segment, but yes.
Right. What happens to you after a stroke.
So,
however, if you want to talk about what happens when you get to the hospital.
So why it's important to get in the hospital? So people ask you, so why it's important to have a primary stroke center? Why it's important to be there on time? Why it's important not to take a nap? Nap sounds pretty good when not feeling well, right? Wrong, because we have this treatment that's available to us. This treatment has become available, first type of treatment, about 25, now almost 30 years ago. It's a clot-busting medication. When somebody showed up in the hospital within 3 hours of onset of the symptoms, and it's a stroke with the blockage, not bleeding one, patient will receive clot-busting medication. It's a molecule that we inject into the veins, and it works like a heat-seeking missile. Find the clot anywhere they can find and dissolve it. Unfortunately, only 5 to 7% of all population have a luxury to get this treatment because the patients don't show up at the doorstep within 3 hours. Because a lot of patients wake up with strokes, nothing you can do about that. But sometimes people just neglect those signs, those BFAST signs. They neglect them, and they don't go right away. They wait until their kids come from home. They wait until weekend's over, and just the wrong thing to do because we can treat those strokes. If anybody will ask me as a professional, what would you change? The only thing I would change, if we'd be very happy if the patient would show it up right away. It would increase my load of work for sure, but I would love to get busy with that. And then we extended hours. We found out that people can be treated within 4.5 hours, which was a very amazing thing. But about 20% to up to a third of all patients have blockages in major blood vessels. And unfortunately, those clot-busting medication was not as effective. And about 10, 15 years ago, we actually started experimenting with the treatment when we deliver the special devices right to the blockage, into the brain. And after many different trials and many different devices, we found the one that works. So we now can go in the brain and open the brain blood vessels, even the patient who have a 6 hours since a stroke, and sometimes even up to 24 hours of a stroke. And we open up the flow to the brain, removing the blockage, and improve the blood flow to the brain and oxygenation of the brain. We good now, we can actually open 50 to 70% of all blood vessels who come to us. It doesn't mean that 50 to 70% of patients will go home with no deficit, but it's for sure decrease the risk of them going home being disabled. We decrease this disability by opening the blood vessel by 50%. So we can open 70% of the blood vessels in the brain, and half of those patients actually do incredibly well, which have a little or no disability, meaning that they basically become independent. Compared to the previous time when those blood vessels were closed, and half of those patients would probably be dying within a year. Because those strokes with the large blood vessel blockage, they're devastating. And now we can go open up 70% of them, and 50% of them end up with little or no deficit. So that's why it's important to be in the hospital as soon as possible. That's why it's important not to take that nap, and recognize that BFAST.
And that initial treatment, and then what do the following hours, days, months look like in terms of treatment, and then also what's life like?
One of the best things you can do, and it's hardcore science, to be in a stroke center of high quality, of high level of experience, had been tested again and again. Even before those miraculous treatments become available, the best thing that you can do if you end up in a hospital who have dedicated stroke floor, have a dedicated stroke neurologist available to you, either in person or on video connection. That by itself is very important because we recognize what's wrong with the patient. We recognize what we can do to find out what's causing that stroke and what we can do to prevent the future strokes, which called secondary prevention. So when we do the initial work, then the second portion of work will begin. And that when we try to figure out what caused the stroke. Is the patient have that irregular heartbeat? If the patient have the carotid disease, which we can go after and open it up. If the patient have a clotting condition. If the patient have uncontrolled diabetes, hypertension, hyperlipidemia, so we introduce the blood thinner medication and cholesterol medication, which does decrease the risk of the future strokes. It may not necessarily going to help that immediate stroke, but it significantly decreases the risk of future strokes. And the third and most important thing, and that's when we're going to pivot to that, what's happened to the people with strokes, it's a rehabilitation stage. So we rush patient to the hospital, we recognize it as strokes, we treated anybody who was there acutely and who have a possibility to open up the blood vessel. They stay in the hospital, we try to figure out what's causing that. We put them on medication to decrease the second stroke, and then we're going to start rehabilitation. And rehabilitation can start, not can start, it will start, should start and will start in the hospital. And when it starts in the hospital, we transition those patients to our rehabilitation facility. But we are so good and better now. And it's, when I started doing that, it was unheard of. Half of our patients go home now because that's how good we are treating the acute strokes and how good we are to starting rehabilitation in the hospital. So half of our patients go home and half of our patients go to rehabilitation. And rehabilitation takes somewhere from a week to 3 to 4 weeks with very intense work. People say like, oh, I'm going to be better at home. Of course, there is nothing better that your own bed. There is nothing better to take care of you than your family members. However, they will not get you to make the therapy 2 hours in the morning, 2 hours at an afternoon like physical therapy will do. And that is very important. If you need the physical therapy in-house, in rehabilitation facility, you should take that opportunity. And after that, our patient hopefully will be able to go home. Now, so when a stroke happens, and this is a very important message when I'm going to get back to that, it doesn't happen to the person. It happens to the whole family around you. And this is very important to recognize for us as a providers when we send patients home on rehab or when they come to us, but it's also to the family. Stroke happens to whole family, and this is meaning that it's all hands on board in the beginning, but it's required the patience and determination. Determination to a simple thing, to be compliant with the medication, and not to despair. Do the therapy, do the exercise that you learn, because recovery takes place. It's not 3 days, it's not 3 weeks. Recovery continues for up to 6 to 18 months after the stroke. And if you lose this precious time in the beginning, you shouldn't get that excited, but if you're losing that precious time in the beginning, you may not capture that toward the end of the treatment. So that's where the all effort has to be directed toward the first 2 weeks, first 2 months, first 6 months of your recovery. And that you will see that, and there's going to be dark days, it's going to be times that you feel like you're not getting any better, but again, that's why you come back to see a neurologist, that's why you come back to see providers who will tell you, listen, you could not move the right arm, and now you can lift it against the gravity. You hardly could hold the fork, and now you can feed yourself. You can go to the bathroom on your own unassisted. That's the small little things, the small little victories that matters. And one more important thing in the recovery, that about up to 30% of patients after the stroke may experience so-called post-stroke depression. That's very important for the family to recognize that, because very often patients wouldn't know that. They're just miserable. They just cannot move their arm, they cannot talk, they cannot understand properly, they cannot get to the bathroom on their own. They get depressed, but they think it's normal. But family sees there is something wrong with them because they start slowing down in the therapy, they're not as participating, they're not as forthcoming with the issues. 30% of the patient, up to 30%, may develop depression after stroke. And it usually happens to the younger patients. So it's very important for the family to recognize that, because early recognition and treatment for this post-stroke depression really improve the outcome.
You have the initial hospital stay, the rehabilitation. You have the extended period of time where you're continuing to do rehabilitation and exercises and such. What does lifetime medicine look like after that?
The terminology of stroke survivors, and we walk away from the stroke victims. We go to stroke survivors. And important how you call it, but the most important thing in recognition of the changing of lifestyle, right? So you may have a deficit, and you have to accept the fact that certain things may not going to go back the way it was before. But again, with the help of your providers and your family and members and everyone else, the recognition is and it should be there for you to see that how much you improve compared to what happened to you in the beginning. And we have these resources here. We have this incredible collective of the neurologists, stroke neurologists, nurse practitioners, PAs, and of course physical therapists who doing incredible job. We have one of the most advanced rehabilitation center in the country now, which can provide incredible way of patients to improve. We have this new device called Vivistem, one of the unique way to implement electrode. They actually help people to move the arm that was paralyzed before. It's just just like from the movies. It's like from a sci-fi, and we can offer our patients here. So we have those things available to us. But again, that's very important to use those resources, not to go home and just, be miserable. It's a tough battle. There is no question about it. But there is resources available to you as your providers, your primary care doctors, who can pick up the phone and call the neurologist that something is going on. Can you see this patient earlier? Us as a neurologist, our APCs and nurse practitioners, and of course rehabilitation services. They in communication with us all the time. I just had today in my office communication with one of the physical therapists, like, hey, so this patient is not improving the way we expected to. We'd like to see him back maybe a little earlier to see if the plan of treatment can be adjusted.
So before we close, of course, May is Stroke Awareness.
Closing already.
I know.
Oh my goodness,
Parting is such sweet sorrow.
I can talk about that, all day long.
Well, there is.
I should have agreed to take the bottle of water, though. That's what was actually much better.
Can you remind our audience one more time what Be Fast stands for?
Yes. If you can take nothing from this podcast except this one, please take it. Be Fast stands for acute onset of balance. B stands for balance abnormalities, balance difficulties, acute severe vertigo. E stands for the eye movements abnormalities, loss of vision or blurry vision. F stands for the face droopiness. A stands for the arm weakness, but where the arm weakness, there is a leg weakness as well. S stands for the speech, and T stands for the time. No napping. Go right to the emergency room. That's the most important thing in a sense. If you have those symptoms, don't take the nap.
Yes, one more question.
One last question. I think it's important. Should you drive yourself or your loved one, or should you call 911?
So it's $1 million question. We believe that 911 is the way to go. However, I got to tell you, half of our patients with the strokes arrive in the hospital in their own vehicles. And again, as much as I would love to say that 911 available everywhere on the dot, if you live in a remote area, they may not be available to you. So I would not fault anybody to jump in the car, but it's definitely safer to do 911 and come to the hospital. We have actually 911 meeting people somewhere in between. So we have actually ambulances and then we have helicopters. I'm not kidding. We have helicopters flying to the remote area to meet the patients who drove from another remote area, and we meet them there and bring them to the hospital. 911 is safer, it's better because we can actually do a lot of things right there in the ambulance. They on the phone with us. We have this mechanism called pre-hospital stroke alert. So the ambulance, when and paramedics, when they see the EMT providers, when they have a patient with stroke, they call the hospitals before they arrive. So me and my stroke team already converging in the emergency room, waiting for them to come. And when they're there, we're waiting for them.
Right.
So that's awesome. So 911 is definitely a preferable way to do that. But again, get there any way possible.
Dr. Isayev, I did so well before.
No, you did very well.
Thank you so much for your time.
Of course, my pleasure. I'm glad to do that.
In case you missed any portion of our Facebook Live event, of course, you can find it on the LVHN Facebook page. And you can also find out by going to lvhn.org/stroke or by calling 888-402-LVHN. I'm Stephanie Wells with iHeartRadio. Have a good evening.